I've been doing this for 24 years, and in 24 years, I see patterns, not just in lab results, though those are revealing in ways I'm going to walk you through today as well, but in stories, in health histories, in the specific combination of things that are slightly off, each one manageable on its own, but together creating an environment in which pregnancy keeps not happening. And here's what I've learned. The pattern almost always precedes the pregnancy, meaning before a woman in my program gets pregnant, there is usually a shift in a specific set of markers, a thyroid pattern that normalizes, a cortisol curve that stabilizes, a gut inflammation marker that drops, a progesterone level that finally holds through the luteal phase. The pregnancy doesn't come out of nowhere. It follows a change in the body, and that change follows identification of the actual root cause. Today, I want to show you the 5 most common clinical patterns I see in women with unexplained infertility. The patterns that, once addressed, tend to precede the outcome they've been working towards. This is not theoretical. This is what I see in clinical practice, month after month, with real women who come to me after being told their infertility was unexplained. And it's what I want you to see too, because the more clearly you can identify where you are in this entire picture, in this entire process, the more specifically you can advocate for what you actually need. For those who aren't aware, I'm Dr. Marc Sklar, the fertility expert. Before we go any further, I created a free guide that I want you to have. It's called The Proven 6 Ways to Improve Egg Quality in 90 Days. Go to the comment section below to get the link. It's completely free. The first pattern I see, and it is by far the most common, is subclinical thyroid dysfunction. TSH is normal, but free T3 is low normal. Reverse T3 is elevated, and often though, not always, thyroid antibodies can be present. I've talked about this in other videos, and I'm going to keep talking about it because I keep seeing the same thing being missed. The thyroid governs so many aspects of the reproductive cycle. It regulates the hypothalamic pituitary signaling that drives ovulation. It affects progesterone synthesis in the luteal phase. It influences the uterine environment for implantation, and it is one of the key modulators of early pregnancy support. What we have to recognize is that many unexplained issues are small imbalances compounding one on top of the other. Any of these issues on their own is likely not enough to cause a significant fertility issue. But multiple factors compounded, that is where we see the problems arise. When thyroid function is even mildly suboptimal, not hypothyroid by conventional standards, but not truly optimal, the effects on the fertility, on your fertility, are real and measurable. Cycles are slightly irregular. Luteal phases are slightly shorter. Progesterone is slightly below where it needs to be. Nothing dramatic, nothing that shows up on a standard panel as abnormal per se, but together a pattern that makes conception harder and early pregnancy harder to sustain. What I see before pregnancy in women with this pattern is free T3 moves from the low end of the reference range to the mid to upper range. Antibodies, if they were present, begin to decline, often after gut work and dietary anti-inflammatory intervention. The cycle becomes more regular. The luteal phase extends by a day or two, and then often, without any other major changes, pregnancy follows. This is not magical. It is physiological. When the thyroid is functioning optimally, the downstream cascade, including the hormonal cascade required for conception, functions better as well. And in women whose infertility was so-called unexplained, we find this pattern more often than any other single factor. The second pattern, closely related to the first and often present alongside it, is HPA axis dysregulation. The cortisol pattern is off. In some women, cortisol is chronically elevated, particularly in the morning, spiking at times when it should be lower or maintaining a flat curve when it really should have a natural rise and fall. In others, particularly those who have been on this fertility journey for a long time, pushing hard, doing everything, running on adrenaline, we see burnout. Cortisol is actually suppressed. The adrenals are fatigued, and the downstream effect on progesterone, on the immune environment, and on overall hormones is significant. What I see before pregnancy in women with this pattern, the cortisol curve normalizes. Morning cortisol comes up if it was suppressed or stabilizes if it was erratic. Evening cortisol drops appropriately. And Crucially, the progesterone production in the second half of the cycle improves. Because once the cortisol steal is resolved, progesterone is no longer being sacrificed to the stress response. The third pattern, gut dysbiosis, and specifically the way gut dysbiosis affects estrogen metabolism and immune function. Here's the picture I see repeatedly. A woman has been eating reasonably well. Maybe she's eliminated gluten and dairy or done a detox. She doesn't have major digestive symptoms, maybe some bloating, maybe occasional irregularity, but nothing alarming. And yet, when we run a comprehensive stool analysis, we find significant imbalances. Pathogenic bacteria, low diversity, fungal overload, intestinal permeability markers that suggest leaky gut. And here's why that matters for your fertility. The gut controls estrogen recycling through a process called estrobolome. When the estrobolome is disrupted, one of two things happens. Either estrogen isn't cleared, circulates at a higher than optimal level, and creates a dominance pattern that disrupts ovulation and implantation, or in some cases, estrogen clearance is overactivated and usable estrogen is lower than it needs to be. More broadly, gut dysbiosis drives systemic inflammation. Systemic inflammation elevates cytokines, immune chemical signals, and that directly interferes with implantation. And in women with autoimmune tendencies like Hashimoto's, which is a common one, an inflamed gut is often the upstream driver of the immune dysregulation affecting reproductive systems. What I see before pregnancy in women with this pattern is that stool markers normalize, diversity increases, inflammatory gut markers drop, and often, simultaneously, estrogen metabolites on repeat testing shift in a healthier direction. The gut and the hormones move together because they are connected. Healing the gut in this context is not just about digestion. It's about creating the systemic environment in which a pregnancy can take hold and be sustained. And this is why gut support and healthy digestive function is so critical in my HOPE program when I support members. Pattern 4 is the one that most surprises women when I bring it up: subtle immune activation. This is distinct from a diagnosable autoimmune condition, though they can overlap. What I'm describing is an immune environment that is slightly overactivated, slightly inflammatory, slightly tilted toward treating and implanting embryo as a foreign object rather than as something to protect. The specific markers I look for are natural killer cell activity, which, when elevated, is associated with recurrent implantation failure and early pregnancy loss. CRP, a general inflammatory marker. Homocysteine, which, when elevated, indicates both folate metabolism problems and an inflammatory state that affects vascular health and implantation. Antiphospholipid antibodies, which causes blood clotting issues in the placental circulation and are linked to recurrent pregnancy loss or miscarriage. None of these appear on a standard reproductive workup. Some of them, like NK cell testing, are still considered controversial by mainstream reproductive medicine, but I have used them clinically for years alongside the women I work with, and the pattern I see is consistent. When these markers are elevated and when we address them, outcomes change. So what does addressing immune activation look like? Well, it starts with dietary anti-inflammatory protocols, specifically an AIP diet for women with elevated antibodies, high-dose omega-3 fatty acids, vitamin D to optimal levels, not just in range levels, and the gut work that I just described, because gut health and immune regulation are one system. They're one and the same. What I see before pregnancy in women with this sort of pattern is inflammatory markers start to drop, antibodies decline, the immune environment shifts from reactive to receptive, and then implantation, which had been failing, succeeds. And the fifth pattern, and I can't say this enough, is male factor that was not fully evaluated. The standard semen analysis is a starting point, but it is not a complete picture. Count, motility, and morphology tell you a lot, but they don't tell you about sperm DNA fragmentation. And DFI above 25% is associated with significantly reduced conception rates and increased miscarriage risk, even when count and motility look normal on a standard semen analysis. In couples with unexplained infertility, I would estimate that 30 to 40% of cases, when we run a DFI test, show elevated sperm DNA fragmentation that had never been identified or addressed. The woman has been doing all the work, her labs are checked repeatedly, you all know this, and then the male factor, the 50% of the equation, has a single normal-looking semen analysis and is considered cleared. This is not a complete investigation. And the clinical pattern I see before pregnancy in these couples when DFI is the missing piece is this. We address the oxidative stress. We run the antioxidant protocol, address lifestyle factors, and use Rejuva male formula specifically. 3 months later, DFI is rechecked. The numbers have dropped from above 25% to below 15%. And within the next 1 or 2 cycles, often conception can happen. I have seen this pattern so many times that I now consider male fertility investigation a non-negotiable part of any unexplained infertility workup. This is a 50-50 journey. The investigation needs to reflect that. If you see yourself in any of these patterns, if you've been given the unexplained label and you're starting to understand what might actually be going on, I want to invite you to apply for a fertility assessment discovery call with my team. We will look at your full picture, not just your reproductive labs, but the complete clinical story and help you understand which of these patterns may be at play for you. I'm going to leave that link in the description below. Let me leave you with this. Unexplained infertility is not random. It is not a mystery that can't be solved. It is a pattern that has not yet been identified because the right questions haven't been asked with the right tools. In 24 years, I have not met a woman whose infertility truly had no cause. Every single time when we looked deeply enough, there was something. And when we addressed it, the outcome typically changed. Bianca is one of those women. Recurrent miscarriages, fibroids, extreme fatigue. She came to us and said, I know something is wrong, but I don't feel like myself, and no one can explain it. When we ran her full panel, we found multiple markers, a baby aspirin that her own doctor had actually noted but never recommended, specific root causes that had been missed entirely. She built her protocol, she felt in control, and for the first time, that was the case. She now has a 9-month-old baby boy. Your situation is not random, and your story is not over. Apply for a fertility assessment discovery call if you're ready for real answers. And for your next video, I've done one on the 5 tests that most doctors never order. The tests that explain why everything you're doing isn't working. That video is going to give you even more specifics. Watch it next. And until the next video, stay fertile and stay hopeful.